Good afternoon, everyone. Thank you for joining CSIS webinars this afternoon. We are having two distinguished guests from Japan. We will be talking about how Japan has been doing so far in dealing with COVID-19. You may have heard from the news, read from the news, but I think this is a good opportunity to listen directly from the so-called authority from Japan. We have Dr. Ohmagari from the disease prevention control, disease control and prevention center in Tokyo, and then we are glad to see Ambassador Iimura. He was formerly the former ambassador of Japan to Indonesia, and now he's with the graduate school GRIPS in Tokyo. Before we go to Dr. Ohmagari, I'd like to invite Pak Iimura for a few words and also to introduce Dr. Ohmagari to us. The floor is yours, Pak Iimura.
Okay, thank you, Phillips. Good afternoon, everyone. My name is Yutaka Iimura, former ambassador of Japan to Indonesia, and currently senior fellow at Graduate Institute for Public Policy. And our institute has been enjoying very close partnership with CSIS. So it is a big pleasure for me to introduce Dr. Ohmagari, one of the best experts on infectious disease in Japan, to my friends and the Indonesian audience. Now, Dr. Ohmagari is in the forefront of the fight against COVID-19, particularly as advisor to the governor of Tokyo. And I think since 3-4 months he has spent busy time, and we appreciate very much to Dr. Ohmagari sharing time with us. And today he has, if I may correct a little bit, what Philip said, that Dr. Ohmagari is director of disease control and prevention at National Center for Global Health and Medicine in Japan. And he has kindly accepted to talk with us what he has experienced and his views on what is going on in Japan and probably beyond Japan. So Dr. Ohmagari, maybe can I pass the front to Dr. Ohmagari, or Phillips, do you want to talk sometime?
Yes, now we just switch microphone to Dr. Ohmagari. The floor is yours, maybe for 20 minutes.
Oh yeah, so shall I start? Oh great, okay. So let me start. So my name is Norio Ohmagari. I'm a director of Disease Control and Prevention Center at National Center for Global Health and Medicine, which is located in Tokyo. Actually, this center is the de facto clinical center of the infectious diseases in our country. And we have been accommodating the patients with COVID-19. I believe more than we had taken care of more than 550 cases of the COVID-19 so far. And first of all, I thank all of the organizers for inviting me to have a talk regarding the issue of a topic about COVID-19 and clinical response to the COVID-19 here in our country, especially in the Tokyo metropolitan area. So I hope that my talk will be of help you to think about how we can cope with this COVID-19 and from now and in the future. So next slide, please. Thank you so much. So this is the epic curve of COVID-19 in our country. And actually, in the very beginning, we had a first case of COVID-19 in late January in our country. And actually, the incidence of COVID-19 was quite small, although we had a very big issue of a cruise ship, the outbreak of the COVID-19 in cruise ship in the beginning and middle of February. However, the incidence was quite small. But the things suddenly changed in the middle of the March. And from the February and March, actually the Japanese government allowed the people from foreign country to really come into our country. And probably which made the dissemination of the COVID-19 all over our country. And we believe that which has caused this surge of the incidence of the patient in the late March in this year. And actually, we had a peak of the incidence in the first and second week of the April, around April 9th. And now the incidence of the COVID-19 is decreasing gradually now. So as of May 29th, 2020, we had a total 16.8 thousand cases, and the mortality is 5.3%. And so this is our situation now. So next slide, please. Thank you. So actually, the biggest incidence was observed in the Tokyo metropolitan area. So I'd like to explain what happened in the Tokyo metropolitan area in the last 2 and 3 months. So this is the incidence of COVID-19 in Tokyo. And blue arrow shows that this is the call for the strong social distancing by the governor that happened March 25th. Actually, based on the epidemiological data, we expected that we might have a quite sharp surge of the incidence of COVID-19 in Tokyo metropolitan area, and which was pretty much resembled to the surge of COVID-19 cases which happened in New York or Italy. So that's why the governor made a strong statement for the social distancing that happened May 25th. And there has been around 7 to 10 days of the discussion between the Tokyo governor and also Japanese government regarding the call for the state of the emergency. But finally, on the April 7th, the government declared state of emergency. Then the peak of the incident decreased. So actually, May 25th, the government declared the total termination of the state of the emergency on May 25th. So it appears that somehow we avoided, overshooting of the cases of COVID-19 in Tokyo metropolitan area, and as well as the other part of the Japan. So next slide, please. So this is the incidence, the distribution of the case of the COVID-19 that is stratified by the age. So we see the peak of the incidence of COVID-19 in the age of the 20s, 30s, 40s, and 50s. And actually, this is the data as of May 6th. And actually, in the early March, actually the peak of the incidence was lying between the 50s and the 60s, but now it's changing. So it appears that now this infectious disease, COVID-19, is quite prevalent in younger age and working age, and which is causing secondary infection to the elderly, like 60s, 70s, 80s. And actually, the peak of the mortality lies between 70s and 80s. So next slide, please. Yeah, this is the mortality of the COVID-19 cases in Japan that is stratified by the age group. As is observed in other countries, we see the peak of the incidence of the mortality, percentage of the mortality in age 70s and 80s. So it appears that as is in other countries, the elderly is at high risk of the mortality in this infectious disease. So next slide, please. So there has been a big discussion and still ongoing discussion about the how many PCR we have to do in each country. And I actually don't know what is the appropriate number of the PCR, but at least we have to see what is the positivity rate of a PCR based on the number of the PCR that is underwent in a given country. this is the positivity rate of PCR testing in our country. And we had a peak of the incidence of COVID-19 around first to second week of April. So at that point, the positivity rate was over 30%. So it appears that during that time, apparently we did not have enough capacity for the PCR. But fortunately, after that, the incidence of new COVID-19 cases decreasing. So since then, the positivity rate of the PCR is fortunately decreasing. Now it is around 1 to 2%. So so that is our situation. But we learned that during the time when we have a peak of the incidence of the COVID-19, we need to do a lot of the PCR testing. So we have to increase the capacity of the PCR testing to cope with the peak incidence of the COVID-19 for the coming time, which actually we do not hope to see. So next slide, please. Yeah. So to increase the capacity for the testing, every country is working on the increase the capacity of the PCR testing. And we are also doing that. But at the same time, we have to increase other capacity of other type of testing. So one method we are now working on is the antigen testing. And the Japanese government approved antigen testing on the May 13th. And we consider that the advantage of the antigen test is the low incidence of false positive. And actually, it doesn't take time. It does need a quite short diagnostic time, less than 30 minutes. And we can supply a lot of the significantly big number of this testing to the market and the community. So now we began to start using this, and we are trying to see if it is useful or not. And one of the problems of the PCR testing is the small hospital and the small clinic cannot have the instrument or facility for the PCR. However, this antigen testing quite easy. So that's why the doctors or the community clinics or small hospital can utilize this kind of the antigen testing. And we believe this will lead to the will shorten the time to onset to the diagnosis of this COVID-19. So next slide, please. Oh, this photo shows the kit for this antigen testing. Now we are using this kind of testing. In a hospital, we began to use this antigen testing in the clinic, the outpatient department, especially emergency department, emergency medicine department, and also infectious diseases clinic. And we hope it works. So next slide, please. So I'd like to change my topic to the treatment. So now we know that the COVID-19 has 3 phases. 3 stratifications based on the severity, which is now shown in the upper side of the blue column. Most of the patients actually doesn't have pneumonia, but maybe 20 or 30% of the patients will develop pneumonia, and probably 5% of the patients will develop quite severe pneumonia, which necessitates the intensive care. So we believe in our country that we have to change our way of the treatment based on the severity of this COVID-19. So in our country, if the patient is if the patient that is not sick and a patient does not have pneumonia, now we are trying to do the RCT for the cyclosporine. This is inhalational steroid, and the purpose of this cyclosporine is a potential ability to preventing the development of the pneumonia. Other drug is favipiravir. This is the originally the drug for the novel influenza. Now we are trying to work this the treatment to as a hope to be a potential treatment for this COVID-19. Now, one Kitasato University, where Professor Ohmagari, who is the inventor of the ivermectin, is a professor. Now they're planning the RCT for the ivermectin, and they are trying to see if the ivermectin can prevent the development of the pneumonia in the cases of the COVID-19. Talking about who had a patient with who had a COVID-19 patient with pneumonia, now we can use remdesivir after the completing a randomized control trial that was done internationally, and we also participated. The Japanese government approved this remdesivir in the late May as an emergency use basis. And we are also using baricitinib on a randomized control trial to see if it can develop, it can prevent the severe type of pneumonia, or in other words, so to speak, cytokine storm. And there are another type of drug, nafamostat. This is actually the originally drug for the DST. However, the Japanese researchers and German researchers found that this nafamostat has antiviral activity, especially for the COVID-19. So now they started also RCT for the nafamostat. For the severe pneumonia, we can use the remdesivir, and now we are trying to, we are now running the randomized control trial for remdesivir versus remdesivir plus baricitinib. And also, we can also use Actemra, this is tocilizumab. This is the international, the cytokine international 6 blockade. As the pharmaceutical company began industry-led clinical trial of the Actemra in this month. And we are also undergoing this the industry-led randomized control, the industry-led trial. Other thing is the convalescent plasma. And talking about SARS and MERS, there is anecdotal report of the use of this convalescent plasma for potential treatment of COVID-19. And we are also trying to see if the safety and effectiveness of this convalescent plasma. The last thing is anticoagulation. Now we are quite aware that some of the patients will develop hypercoagulability in the course of COVID-19, and a significant number of the patients will develop embolic events like cerebral infarction or cardiac ischemia or peripheral artery occlusion because of this hypercoagulability. So we believe that the utilization of anticoagulation medication would be a key to prevent those kind of significant complications because of the COVID-19. So next slide, please. So I'd like to show one case which we experienced. This is a quite severe case. This is a 66 years old male from US who came to Japan with Diamond Princess, that was a cruise ship, and he developed COVID-19 common cold in that. And after 1 week of the period of common cold, he gradually developed a severe respiratory failure. And in 2 days, he developed acute respiratory distress syndrome. And this is the chest X-ray which was taken on that day. He developed, so to speak, ARDS. So next slide, please. Yes, thank you so much. So in 2 or 3 days after the development of respiratory failure, we had to introduce mechanical ventilation to this patient, but it didn't give him enough oxygenation. So that's why we introduced extracorporeal membranous oxygenation, so to speak, ECMO, for the to save this patient. But it surprisingly took a long time. Actually, we had to put him on ECMO around 6 weeks. We've never experienced utilizing this ECMO for a long time like this. But after 3 weeks of the treatment with ECMO, he gradually, improved. And we took him off ECMO after 3 weeks. And actually, eventually, he was taken off from the mechanical ventilator. Although it took him to almost 3 months for the recovery, but unfortunately, he went back to US, Colorado 2 weeks ago. We were very happy. But we learned 2 things through this patient, that well, there is a quite significant percentage of the patients with COVID-19 who need intensive care, and it take a long time for these patients to recover, 3 weeks, 4 weeks, or more than longer that. But if we can do, this kind of the how you can say, supportive care successfully, we can save this patient. But it takes a lot of human resources, and it takes a lot of the medical resources to save this patient. So that is the thing. So we can do this. However, supposing that we have a overshoot over COVID-19, which we do not want that, maybe we cannot do this for all the patients. So we learned through this case that, well, the priority is, control of the, prevention of the overshoot, control of the incidence of the COVID-19. I mean, in other words, decreasing the total number of the incidence of COVID-19, which is the priority, we believe, although we are clinicians. So next slide, please. To accommodate a patient with COVID-19, we have to keep a bed. So this is a diagram which shows what is the model we use in Tokyo metropolitan area to accommodate a patient with the COVID-19. So in Tokyo metropolitan area, we expected that at least 4,000 patients need admission on a given single day during the peak of the COVID-19. So in that case, after the diagnosis of COVID-19, if the patient status is moderate to severe case, we have to admit the patient to the hospital. However, in those situations, almost 16,000 of the mild or asymptomatic case will appear to the hospital, which we cannot accommodate in the hospital. So the Tokyo metropolitan government introduced hotel care to accommodate the patient with mild to moderate COVID-19 cases. And in the very beginning, actually, Tokyo metropolitan government was thinking about introduction of home care. I mean, sending the patient with mild disease to the home care. However, now we learned that some of the patients at home care may die suddenly because of the probably complication of the thrombotic event. So now the government and the Tokyo metropolitan government does not want the patient to send home, but they prefer to send the patient with mild or moderate infectious diseases to hotel care. So this is the way we responded to the surge of the cases of COVID-19 in April and May. So next slide, please. Although I'm sorry, some of the characters are written in Japanese, but basically I'd like to show you that the Tokyo metropolitan government was prepared to have 4,000 beds, and 700 beds is for the patient with severe cases. I mean, in other words, the Tokyo metropolitan government prepared 700 ICU beds in our metropolitan area, and Tokyo metropolitan government also prepared 3,300 beds for the moderate case. Next slide, please. So lastly, I'd like to talk about the containment, or could be a mitigation of COVID-19 in our country. Through the experience of COVID-19 from January to March, we learned that significant, the big number of the patients will come from the cluster, the groups of the patients. This is a map which shows where we had a big cluster of COVID-19. Next slide, please. Thank you so much. Through the experience of the COVID-19, now we learned from our experience in our country that approximately 80% of the patients does not affect anybody, so they can be affected. However, they didn't transmit this COVID-19 to other people at all. However, the rest of the 20 patients was patients transmitted this COVID-19 to other people. Not single or not second, but a lot of numbers of patients is affected by this. These 20% of the patients. I mean, in other words, this 20% of the patients was the origin of the big cluster. So from this experience, we learned that controlling, or prevention of the cluster is a key point of the containment or mitigation of a total incidence of COVID-19 in our country. So next slide, please. And now we know that this cluster is associated with 3 risk factors. This is 3C. In Japanese, we call that 3 mitsu, but in English, we call this 3C. The first one is the closed spaces with insufficient ventilation. And the second one is the crowded conditions with the people. And the third one is a conversation in short distance. This is 3C. And we believe that if there is a situation which has all 3Cs, which is a situation that is a high risk of the occurrence of clusters. So now the Japanese government is calling upon the general public to avoid these 3C places or 3C occasions. So next slide, please. And I'd like to also say that the Japanese government also calling upon the people to have a masking when they go out, and when they go into the inevitably go into the situation of the 3Cs. Now we know by scientific evidence that just speaking or making a boy like this will make a splash. The aerosol, which can transmit the virus to the other people. To prevent that, the masking is quite important. So the Japanese government is calling upon general public for the, so to speak, universal masking. But I think it's actually quite familiar with the Asian country people. So this is my last slide, and my presentation is quite open to a discussion. Thank you so much.
Thank you, Dr. Ohmagari, for very informative and interesting presentation. I do have a number of questions, but before I'd like to inform participants, those on YouTube, you can actually post questions through the comment column on YouTube, and it will be relayed to Zoom. And those of you on Zoom can also post question in the Q&A tab down on your screen, Zoom screen, and then you can post your question there. Now, if I may start with my question, Dr. Ohmagari.
Sure.
At least for now, I have 2 questions. As more on the non-medical side of this COVID-19 experience in Japan. You mentioned about the antigen testing, and I saw in the slides that in the footnotes that it was developed by the industry academic collaboration. And this thing, I think, something to be learned from Indonesia, how Japan, probably before the COVID-19, crisis, hit this environment of close collaboration between academia and the government and industry in terms of, developing medicines and how they actually do collaborate now in dealing with COVID-19.
I'd like to say that, actually, historically, the academia and the industry has been in a close place. In other words, has been working pretty closely for the development of this kind of the tool. But so our relation was quite good. But what was the most striking change is the, I would like to say that the attitude of the government, I'd like to say. Relaxing the regulation. In the usual time, in a calm time, it takes a lot of time for the Japanese government to go through all the regulatory processes. It takes a lot of time. But during this emergency situation, it cannot be, it shouldn't happen. So actually, the government shortened the time of the certification. For this kind of new technique. by reducing the regulatory process, which necessitate, which actually, so that's why all the industry can send those kind of new techniques to the commercial market in a quite short period. I think that is the most significant point of the change during this outbreak.
Okay. Yeah. Thank you. And secondly, there's a very interesting number that you are presenting. You were referring to the fact that 80% in the experience of Japan, 80% of those infected have not infected others. Why do you think is it? Is it because they are very disciplined people? The time that they know that they contract virus, so they have to distance themselves, or it's some kind of immune system? I don't know. Maybe you could elaborate a little bit on that.
In my assumption that probably 80% of the patients who are affected probably did not get into the high-risk places, high-risk 3C places after they got this infectious diseases. Once they get into the high-risk places, so to speak, 3C places, I assume that they have transmitted this infectious disease for a significant number of other people. But fortunately, this 80% of the patients did not go to anywhere. Well, may have gone to anywhere, and they didn't have a chance to get into the so to speak, 3C places. So in other words, we should not have only even single patient in the 3C places. Yeah. So to avoid that, we can avoid significant number of the patient in clusters. So that is what I believe.
Okay.
Yeah.
So maybe this is related to the question posted by our participants. There are a number of questions here. I'm gonna choose the most relevant one with the one that you just stated. In your opinion, what's the strongest out of so many options policy available for Japan? What is the one that contribute the most to the relatively low number of people contracting virus in Japan?
I see. I myself believe that called by the Japanese government and also called by the Tokyo governor was quite strong in terms of the containment, which I believe. And actually, on May 25th, the Tokyo governor called upon the general public that the first one is avoid 3C places, and the second one is the so to speak physical distancing. In other words, social distancing. But that was not the order. That was how I can say they just called upon the people. Yeah, but actually it worked.
So you were saying that on the part of the people, there are people are acting in accordance to the call by the government.
Yeah, I
so
think so.
It seems that there's this cultural thing with people in Japan, full of trust to the government, maybe, or some other factors that you may elaborate.
I believe that they trust the government, but I believe that I believe that the message by the governor was quite strong enough for the people to believe that this is a very deadly disease, which we have to avoid, and we have to do something for the the society. And actually, I still believe that on the next stage of the the statement by the governor of the Tokyo, the number of the people on the street, the number of the people in the subway was quite small. It was quite surprising. Also, it was based on any order. It was just a call from the governor. So by seeing that, I learned that the conveying a strong and conveying a simple, easy to understand message quite important. Especially in our country.
I see. So the crisis communication works well, I think, from the part of the government, either in Tokyo metropolitan.
Yeah.
Now there's a question from Muhammad Habib. Given the fact that Japan has also been very experienced in disaster management, does Japan also mobilize stakeholders on disaster management to address COVID-19 issues?
Thank you so much.
Yeah.
Yeah, actually we did. And, the disaster management personnel was quite helpful, and they were quite skillful. Well, I still remember when we had an incident of the, so to speak, Diamond Princess, the cruise ship, an outbreak of COVID-19 cruise ship, where, the disaster team played a lot of work. Actually, we have a system which is called DMAT, which is the organized team to cope with the organized team of the health personnel which cope with the disaster. And they have a team all over Japan. And actually, under the order of the DMAT, some of the more than a couple of team of DMAT got together to the Diamond Princess, where they did the operation of the infectious diseases. And the second thing that the team for the disaster was quite helpful was controlling of the, how I can say, the management of the control center of each local government. They are quite good at handling the bed. They are quite good at where is a vacant bed, and now they are quite good at where is a patient who are not hospitalized. So they are quite good at matching those vacant bed and the patient. So as one of the operation for the disaster response, they have to manage the allocation of the patient to the specified hospital. And I think that those skills that was cultured in the disaster response was quite helpful for the management of the bed.
I see. Thank you. There's this question from our participant on YouTube, Rizka Rezalia. Indonesia and also I believe Japan, we are now talking about new normal. New normal. What strategy is prepared by the government or maybe the governor of Tokyo to enter the new normal phase? Because there's also risk when we kind of losing our guard because people feels that it's already okay, you can go to restaurant, hospitals, schools, and so on. There's always possibility of the second outbreak of the virus. So what is the strategy by your center or the governor to enter this new normal environment?
Well, everybody hopes that relaxing the regulation, I mean, this is a constraint because of the the social distancing to contain contain COVID-19. However, they are quite feared about the COVID-19 at the same time. So the governor is still calling upon the importance of the avoiding 3C, closed places, those kind of things. So, and also the government and the Tokyo metropolitan government is, I can say, ordering all the industries, all the small shops to, or also to the schools or to the, the government facilities to make a guideline for the operation for the new normal. That is based on the concept of the avoiding 3Cs. And so that is the thing actually, So, but I think that what is written, our guideline for the normalization, I mean getting back to the normal, is pretty much similar to the what is written in the guideline in other countries. But I'd like to say that we are stressing that well, the center of the principle is the avoiding 3C. So we have to start from that point, So we have a problem with what we can do in the given situation. We start with the thinking about how we can avoid 3C in the given situation. So that is the message, that is the tactics we are taking in the country.
Okay, so following that up, this is from somebody from YouTube asking how the punishment mechanism work for those who are not socially responsible. Is there such a kind of a mechanism for people who are not socially responsible? Because it seems to, from your explanation, seems that the participation of the people play a very big role in Japan.
Okay, thank you. Actually, we do not have any punishment, but at the same time, in the very beginning, also it might sound quite weird, but anyway, let me tell we didn't have any punishment, but at the same time, we didn't have any compensation for the social distancing. That was a problem. Actually, there is still a big discussion about the lack of compensation by the local government and the central government. But some local government started self compensation by themselves. They made their own rule for the compensation, and they gave a right for the compensation if the shops and owner of the small shops and also could be also big company is obeying the call by the local government, the call for the social distancing or call for the closing the shop in under the statement of the emergency. So if they need a compensation, they have to obey. That was the mechanism.
Okay.
Yeah.
In essence, there is in some local governments there is this incentive structure provided by the local government for the shops, local businesses, to close down and to follow the call from the local government. Okay. Right. I think that's very interesting because what we know, Japan is well known for the people who are kind of obedient people, living in conformity, and that might contribute to the lowering number of the COVID-19 cases. Now, there's a question. This is a technical question. I'm not a doctor, but and there's a question from YouTube as well. Can anti-parasitic ivermectin be chosen as COVID-19 prophylactic drug?
In general, I mean,
okay.
Well, we hope that, but we don't know what happened when they give this ivermectin, anti-parasitic drug to the mild or mild COVID-19 patient, or could be the people who had highly close contact with the patient COVID-19. We don't know for sure, but to see that we are now, the Kitasato University is preparing for the randomized control trial to see the effectiveness. And we hope it works.
I see. So, related to the question, how Japan is contributing to this race to find the vaccine? Part of a kind of a global consortium in the labs and virologists that working very hard to find this vaccine.
I see. Well, what I know is there is a large international consortium for the development of vaccine. So the Japanese government, central Japanese government is donating, giving a fund to this consortium. This is the first phase. The second thing is there are a lot of significant number of small or big companies who is involved in that are involved in the development of the vaccination. They are working on it with the help of the academia. So I think those are the things. Nothing special. Those kind of things. Yeah.
So far, like you mentioned, the existing treatment, be they remdesivir, Actemra, nafamostat, anticoagulation that you explained in your presentation, are still the most preferred treatment for COVID-19.
I see. Yeah. Well, now we know that remdesivir will shorten the period of the period of diseases. So we prefer to use the remdesivir for the patient with moderate to severe COVID-19. Although the supply of the remdesivir is not big, however, fortunately the incidence of the COVID-19 is quite small now in our country. So we now have enough number of remdesivir. Otherwise, there are a lot of the candidates for the treatment of the COVID-19, but honestly speaking, we don't know what should work. So now we are waiting for the result of the randomized control trial for other medications, including the tocilizumab or other antiviral drugs.
Okay. Now, you mentioned in the presentation in terms of age group of those who are contracting COVID-19 virus, it seems that the young ones seems to, meaning the group of people who are in their 20, 30, 40, 50.
Yeah.
More likely to contract the virus, but the mortality rate is still higher among those in the older age group, 60, 70, 80. Now, the question will be, in terms of comorbidity in Japan, in this age group that is more deadly, seems to be, what are the main cause? Some areas reported this diabetes,
Yeah.
or with the heart problems and so on. In the case of Japan, what are the comorbids?
Yeah. Well, what we now know that apparently the elderly is at high risk for the developing severe COVID-19. But otherwise, we just started undergoing the registry study. I mean the study for the large number of the patients to see the risk factor for the development of the severe COVID-19. So I cannot tell the result of it right now. So, but what I can tell based on my experience is the risk factor appears to be pretty much same to the factors that is reported from the Chinese articles, or the articles coming from the US or Europe, like smoking, hypertension, diabetes, and cardiovascular diseases, and chronic obstructive pulmonary diseases appears to be a quite risk factor for the development of severe COVID-19 based on my experience.
Right. But given the fact that Japan is kind of an aging society, it's quite surprising that the number is still low.
Yeah.
What do you think is a major contributing factor for this?
Well, honestly, I don't know, but it's quite curious that I know more than a couple of the patients with elderly patients, not more than a couple, significant number of the elderly patients who acquired COVID-19, but even in their 80s, 90s, surprising. However, significant fraction of those patients did not develop any bad COVID-19 pneumonia, just common cold. Surprising. So but it's turning out that if we can live longer enough, that means that we are healthy enough to live longer. They might have some secret in their body in terms of the living longer. So it appears that probably compared to the ordinary elderly, the patient who just developed mild COVID-19 has probably the quite good immune system. That is my assumption.
I see. Okay. So we would be very interested in the learning the large study that is going in Japan.
We look into that. We stratify the elderly patient into the no comorbidity with comorbidity, and to see if there is any difference.
Okay. So there's this question from Rafaela. The question is, every time Prime Minister Abe makes statement concerning his administration's decision on measures for COVID-19, he always says, upon listening to expert opinion, I will decide such and such. Now, in this context, who are the experts that he is referring to? Is it medical doctors, economists, or we don't know? Would you kindly explain that?
Sure. Up until the beginning of first half of the May, the expert panel was composed by mostly from the healthcare personnel, and epidemiologists, and there are one lawyer and two social scientists, and one quite pure specialist for the research for the respiratory viruses. So basically, there was some quite small number of the non-expert of the healthcare, but most of the member was coming from the field of healthcare. But now there was a big discussion about the after this lockdown, not lockdown, after the state of the emergency of the government of Japan, there began a lot of the big discussion about who is the expert, who should be in the expert panel. Now the Japanese government introduced 2 or 3 economists into the expert panel to see the economical side of the, how can I say, effectiveness and also bad effect of the state of the emergency. So now healthcare personnel, lawyers, social scientists, and also the economists are in the expert panel.
So the economists came later to the
Later, yes.
So
Yeah.
that in the beginning, it's really health that is the major focus of the Japanese government,
Right.
to deal with this. But then later on, economists, were invited to the expert panel.
Right.
Mhm. Okay, it seems to be a different discussion here in Indonesia because
Okay. Oh, really?
economists, the economic side of things, kind of equally weighed by the government in dealing with the COVID-19.
Yeah.
But that will be a very interesting comparison. Now, there is another question that I'd like to ask. The 3C places that you mentioned, closed space, crowd, and conversation in short this time. How the government enforce this? Do you close these closed spaces, or it's just a call, but there's no enforcement or no more detailed implementation of this, the avoidance of 3 places that people should not go into?
Okay, sure. The Japanese government stratifies the places into like a 2 or 3 categories: high risk, moderate risk, low risk. So they started to relax the rule from the low risk places. And if they can, those shops or those industry fields can make a very reasonable guideline guideline for the containment COVID-19 based on the idea of 3C. So, in some cases, we cannot avoid 3C places, but we can reduce the risk of reduce the risk of transmission of COVID-19 by, how you can say, improving the situation, like, opening the window or wearing a mask or having a distance each other at least 2 meters, like that. So by introducing those kind of the quite simple principle, they develop a guideline. And if the government believes that the guideline is quite feasible enough to reduce the risk of the COVID-19, they say that, okay, we can open this kind of places, low risk places. And then if if nothing happens, if then they deduct the rule to the places for the moderate risk. And such a sense, then finally we can open the high risk places, like, how I can say, the karaoke station, like, the gym, small gyms. They have a training. And actually we had the big cluster in those kind of high risk places by doing that.
Okay, thank you. There's this question from our participant on YouTube, Elsandra. If we may seek your expert view on herd immunity.
Okay, wow.
What do you think about herd immunity?
Herd immunity. I'm still not sure about if you have herd immunity for this COVID-19. That is my only, that is my honest, opinion. Because in the ordinary coronavirus, we know that there is a 4 ordinary coronavirus which causes common cold yearly and every year. And it's apparent that we do not have herd immunity for this quite common coronavirus. So, and there are some limited number of reports about the immunity after the infection of the SARS coronavirus 2. But it sounds like, and it appears that they may not have, we may not, how I can say, develop persistent immunity. The virus for the COVID-19. So I'm not sure at this point if our society can develop the herd immunity this COVID-19. But I had a discussion with the immunologist, But his idea is quite interesting. We see that if we see that one of the barometer of the herd immunity is the prevalence of the so to speak antibody, like IgG and IgM, the percentage of the antibody, IgG and IgM antibody in the given population. But the immunologist told me that but we can develop significant immunity to the how I can say this coronavirus without developing a significant number of antibodies. So just having a positive antibody does not mean that we are, I was wrong. The negative antibody, just having a negative antibody by the test does not mean that we don't have any immunity. Mm. So the things are the things are quite complicated. So honestly, so again, I cannot tell if we can develop our new immunity in a society by this COVID-19, but I hope it.
Okay. Thank you. I believe there will be so much debate about this because some countries pursue, the idea of, in every in certain level, kind of believing herd immunity will be there.
Actually, some government was building their plan for the containment on the basis that there is herd immunity. So, but actually, it's now doubted. So we have to be very careful in terms of that.
Yes.
Yeah.
Okay. Yeah. Now, also in the presentation, you presented clusters in Japan, and if we may hear from you more on the how do you control clusters, because they happen in different dates and different parts of Japan, and how do you actually control this spread of clusters so they are not becoming the super spreader?
I see. Yeah. First one is the by finding out all the cases of the COVID-19, we try to find out if there is any cluster, hidden cluster. But if we can find clusters, we can find that the people who were in that cluster, who may not be symptomatic or asymptomatic, and we do the contact tracing for that. And by doing enough contact tracing right after the finding of the clusters, we see that who might develop this COVID-19 in a given period. And also we undergo the isolation for those patients with COVID-19 or who had a close contact with the patient with COVID-19. By doing that, we believe that we can prevent all of those people can get into another 3C places and it will be the first index patient for the cluster. So in that way, we are trying to make preventing the development of cluster from cluster. We believe that the series of the cluster will be most dangerous. One cluster, well, we cannot avoid it, but if we do a good epidemiological pursuit and undergoing the isolation policies, we can probably cut the chain of the cluster. So by doing that, we can we can contain that. And second thing is by knowing the research of the cluster, now we can know that what is the high risk place for the cluster. So now the Japanese, in all of our country, most of the high risk place of the cluster is still closed. Like how I can say the karaoke shop, or like a gymnasium, or how I can say the music house as well. They're closed. So now by doing that, we can see what is the high risk places, and we can make an order to close those places. That is what we do.
Yeah. So related to that, in terms of tracking and tracing, how big is the investment in doing the tracking and tracing? Is it organized by local government or by your center, or who has the responsibility for this tracing and tracking?
In Japan, in those how I can say medical area, we have so to speak public health department, which is run by the local government, and they have expertise to the contact tracing. So basically, the public health department is the key player for the contact tracing. they are quite capable. However, one issue is that they don't have enough human resources to do, extensive the contact tracing, which became a very big issue in our country in the last couple of months. So we do hope that we have to increase the capacity of the contact tracing by increasing the human resources on the public health department. They're quite precious.
Thank you. So there's this question again from YouTube, from Patricia Budiman. There's new cases, probably second wave in Japan.
Yeah.
You can decide on us. How is the government preparing for second wave, especially with the new cases in Kitakyushu?
Yep.
Yeah.
Now government is thinking about concentrating on more than couple of the high risk, how I can say, situation, high risk, places. The first one is the, how I can say, the first one is the healthcare facilities, especially small and middle-sized healthcare facilities. They are quite at high risk for the development of the clusters. So now they are increasing the capacity for those small hospitals and the clinics for the infection prevention, because they have been quite weak in terms of the infection prevention control. And the second thing is the, now we believe that, still, how I can say, so to speak, the shops that is running in the nighttime, like, so to speak, nightclubs, or, dance club, or, the pubs, those kind of places is quite at high risk. So, so now they're thinking of how they can stop, the occurrence of cluster in those night areas. The third one is the, the border control. Now we learned from the experience in the last February and March that, we had one very big mistake. That was the loss of border control, which probably created a very, very big first wave of the COVID-19 in the country. So now, but also we have to relax the border control because of the economy. So now the government is quite seriously thinking about how we can do the border control by also relaxing the border control to accommodate the influx of the businessmen, tourists from other countries.
Right. So
with those two places.
Yeah. U.S. is going to open their economy.
Oh yeah.
There will be, more now again influx of flights to and from the U.S. and given the close relationship in economic terms between Japan and the U.S., you might expect to have now influx from people from the U.S. to Japan and vice versa. And we know U.S. is kind of the red zone for every country now.
Oh yeah, it is. Yeah.
In Tokyo.
Well, now
their economy.
Oh yeah. Now actually the government is under discussion how we can accommodate those people from the high risk country. But we learned that from the experience of the so to speak Diamond Princess, we can stop the secondary transmission of the COVID-19 by doing the good contact tracing after at least 14 days after the embarkment of the ship. So we can do the similar thing. So if we can, we can access those people from other countries, but by doing quite, good, quite, capable and efficient, how I guess, so to speak, contact tracing. They are not contact, but the tracing of those people coming into our country at least 14 days. I think that is the key. So now the Japanese government is thinking about the introduction of the, so to speak, iPhone application for the contact tracing, and sharing the information of those information of the contact to the the local government. So yeah, those kind of things. Yeah.
Right. We have a few minutes left, but you show your phone, and Japan is kind of a highly technological society. Technology is contributing in the effort in Japan in coping with COVID-19 so far.
I'd like to say that we are not utilizing the the power of the information technology fully. And I think that is the biggest barrier is the how I can say the protecting privacy information of the people. We have a law, quite very strong law for the keeping private information. I think that is quite important. However, that might be a quite a big barrier for the utilization of this information technology, which we have to really think about it. In terms of the containment of infectious diseases, we have to utilize this kind of the personal information by not invading their right and the human right and the human dignity. That is a big issue in Japan, and now we have been having the big discussion about it.
So
Yeah, so, sorry.
You were saying that because of this concern about protecting private information technology has not been fully utilized
That's right. Yeah. Thank you so much. That's a good summary. Yeah. That is my opinion.
Oh, okay. Oh, that's interesting because
Mm.
I personally thought technology play a huge part in the Japanese success in lowering the number, but it seems it's
Yeah.
the opposite.
Actually, I'm learning from the Asian countries for the utilization of IT.
I see.
I'm so how I can say MBO. Because
Okay.
we have big barrier with the private information.
All right.
Right.
So maybe this is the kind of the few last question. You are experienced with WHO and in your on your I read on your
Okay,
CV.
sure.
So what do you think we should be in terms of international cooperation? You are referring to the Japan. Even Japan has the problem of capacity of a public health official at the subnational level and so on. So do you have any views on the international cooperations to prevent a future pandemic or other kind of disasters?
I think the international cooperation is quite critical critical for the containment of this kind of infectious diseases. So just sharing information each other will be quite informative. Although sometimes information about the incidence of infectious diseases might be quite top secret for the given country. I know that. However, we still have to share the information for the preparedness. And you mentioned about the utilization of information technology, and which is actually quite useful. And those kind of the exchange of the knowledge in terms of the practical containment of the infection, this COVID-19 is also quite important. So in that way, I think at least the bilateral, the information sharing, and also unilateral information sharing is quite important. In terms of WHO, I know that there is a big discussion about it, and but I personally felt that sometimes sometimes the WHO just require information, just give us the information. That's what WHO says. But we frontline healthcare personnel doesn't have a time to prepare data to give a WHO. That is my honest feeling.
Right.
So I know I understand that they need the information, but I think that WHO should be the body for the help. To help the country to have a knowledge about it. So
right. I personally think East Asian country, especially China, Japan, South Korea, are the ones that have been quite successful in mobilizing resources and tackling the problem of COVID-19 in their countries. And I personally believe there are a lot to be shared by these.
Oh yeah, sure.
In Japan, and so East Asia, even Taiwan, I think may be the ones to look for in terms of leading the international cooperation for this, preventing future pandemics. Lastly, my question is, you before we started, you mentioned about the cooperation between yourself or your agency with the hospital in Jakarta, Sulianti Suroso.
Oh yeah.
That's the main hospital in Indonesia that has been tasked in dealing with COVID-19. So if I may solicit your view, how Japan and Indonesia can collaborate more in these areas. because we have such a young population while Japan has a kind of an aging society. We have at the two sides of the problem, you know, and tackling this. And there is existing cooperation like what you've been doing with our Sulianti Suroso Hospital in Jakarta.
Yeah, you know, I think they, you know, we just you know, having exchange of the knowledge and experience would be quite helpful. You know, actually, I learned a lot from the experience from Indonesia and people from the Sulianti Saroso. For example, regarding the clinical management and you know, the containment of the clinical management and also control of the dengue. It is quite prevalent in the country, and we have less it's less prevalent in the country. And we also I learned a lot from the experience of having the avian influenza H5N1 in your country. And the Sulianti Saroso people took care of their patients with H5N1 quite nicely, which I learned a lot. And what we can do is we can tell our experience of the taking care of the patient, elderly patients with infectious diseases, as you mentioned, you know, in this given extremely aged population. So those kind of things. So we do have a lot of change, cultural change, society change, the change in the difference in the diversity in the society and population, and which means that we have a different type of the issues and a different type of infectious disease each other, which we can communicate and we can exchange the experience knowledge. By doing that, we can learn a lot and develop the future relationship, and hopefully we'll go to the future research and the development.
Yeah. So Dr. Ohmagari, thank you very much. Before we end, I'm not sure if Ambassador Iimura is still with us. Ambassador Iimura, could you hear me?
Yes,
Yeah.
I'm with you. Wait,
Right.
do you hear me?
Yeah.
Yeah.
Would you have some kind of a closing remarks on this? You know, you were the ambassador, and I know under your time in Jakarta, there were a lot of good cooperation between Japan and Indonesia. The last point that Dr. Ohmagari mentioned may have, you know, may be relevant for us now, but you may have some, I think, wise recommendation for us how we can work closely.
Well, Philips, thank you very much. Before talking about possible cooperation between Indonesia and Japan bilaterally, I just want to say one thing. I noticed that one question regarding how Japanese government or local authority can enforce the decisions without any punishment. That was the question raised several times. And this is one of the mysteries we do also have. But my personal opinion is in Japan, probably given the cultural tradition, there is a very strong social pressure. If you don't follow what the government does recommend, the government can only recommend because there's no legal basis for enforce something that they decide. So how you can enforce this without possible punishment? I think what Japanese feel is social pressure, kind of peer pressure, and even media plays an important role. When the restaurants or nightclubs, well, particularly those active during the nightlife, if there are some shops or some nightclubs and bars do not obey, do not follow the government or local authorities' recommendation, then there's not only social pressure but also media pressure. I think media has been playing very important role. And secondly, probably this is the area that Dr. Ohmagari knows very well. the Japanese society, generally speaking, the people are very health conscious. Even when you are in kindergarten, I do remember when I was in the kindergarten, my parents always said every day you have to wash your hands, you have to do this and that. So this is also part of culture. Being health conscious is part of culture, and it might have been working positively this time. Of course, we have to see because the second we may have second or third waves, but so far the reason why this we have been fairly successful in containing spread of COVID-19, partly due to the health cultural background and also social pressure, peer pressure. That's one thing I just wanted to add. And finally, how we can collaborate between Japan and Indonesia. Of course, this is one of the questions that we should discuss. But I want to remind you that Prime Minister Abe, when he declared lifting restrictions on it was just 10 days ago, he emphasized the importance of international collaboration. I think so far we have been focusing domestically what we can do. We have spent most of energy on this, on containing, but now we have probably a little bit more energy to think about collaboration with other countries. And I think Indonesia is a very close friend. And we do have lots of Indonesians living in Japan. We do have now increasing number of Indonesian tourists coming to Japan, and also Japanese tourists coming here, and also lots of exchanges, academic culture exchanges. And Dr. Ohmagari has been involved in this exchange between the two hospitals. I think how we can structure this future collaboration, I think we should do take a down to earth approach, not only slogan, but concretely what we can do to find out these concrete steps to take is very important. At this stage, as I'm not expert, I cannot go into the detail, but maybe CSIS and my institute, Graduate Institute for Public Policy, can work together to find the ways to promote collaboration between Indonesia and Japan. Thank you. It has been very useful. Dr. Ohmagari, thank you very much.
Thank you so much.
Thank you for your time, and Ambassador Iimura, thank you for helping us connecting with Dr. Ohmagari. It's been very useful and very informative. I believe we learned a lot. We will write this up, a summary of the discussion. And it will be available on YouTube for a long time, so people can revisit our discussion today and sometimes in the future. And we look forward to collaborate more with Dr. Ohmagari and also with GRIPS and Ambassador Iimura in Tokyo. Thank you very much. And those who are participating, thank you. We look forward to welcome you in CSIS other event. Good afternoon and stay healthy, everyone. Thank you.
Thank you.
Thank you very much.